So these patients have hepatitis. They might also have some psychiatric symptoms, mainly because the copper likes to deposit in the basal ganglia. And then you can see those common Kaiser-Fleischer rings in the cornea. All right. Most common bugs causing meningitis. Name me some. Strep pneumo, Neisseria meningitidis, and H flu. Listeria we worry about in the old and young. So in little bitty babies and in old people or anybody who's immunocompromised, we'll also think about listeria and so add ampicillin to our treatment regimen. In people who've been recently instrumented in the brain, now we worry about staph and we treat that with Vanc. Some other random causes, tuberculosis, remember, can also infect the meninges, and we add steroids to our RIPE therapy for meningeal tuberculosis. And Lyme disease can mimic almost everything. Lyme disease really sucks because any clinical presentation could be Lyme. I don't know. So we treat Lyme meningitis differently than regular Lyme disease. We have to give IV ceftriaxone because it penetrates the blood-brain barrier. So if you have a patient you're suspecting meningitis, what's the best first step? Antibiotics first, and before you do the LP, remember you always want to check for signs of intracranial pressure. So, look in the eyeballs, look for optic swelling. If it's indicated, get a CT to make sure there's no intracranial swelling. But really the most important first step is to start empiric treatment, especially if they've got like horrible bruising, spotted rash, you think it's meningitis. So what about if you're the roommate of the kid who has Neisseria meningitis? Rifampin. Good. So random, right? Rifampin is Neisseria meningitidis prophylaxis. So you give that to close contacts of known disease. So for pneumonia, if you are thinking the patient has pneumonia, what would you do first? Good. We want to see it. And what's the most common bug causing pneumonia? Strep pneumo. Most common bug in you and me, healthy young people, hopefully. The atypicals, right? So mycoplasma is the most common, and that, remember, is associated with cold agglutinins, and we treat it a little bit differently. A macrolide is the first line of treatment here. If the patient is hospitalized within 3 months or is in the hospital for more than a week, we start worrying about HAP, hospital-acquired pneumonia, or healthcare-associated pneumonia, and those bugs are a little bit different. What bugs are we worrying about there? Pseudomonas, Klebsiella, E. coli are the main ones. And the treatment's a little bit different there as well. Old smokers with COPD are more prone to a certain kind of pneumonia. H flu. Old smokers with COPD more likely to get H flu. The alcoholics who have the current jelly sputum, there's Klebsiella. And the old dudes who hang out in the hot tubs, that's Legionella. Joe Dannebaum always talks about that. He's like the old man in the hot tub. He has Legionella. I don't know why. So a lot of books describe Legionella pneumonia as pneumonia plus. So it's the common respiratory symptoms of pneumonia, but they also might have diarrhea. They might have altered mental status. So it's pneumonia plus syndrome is Legionella. If they just had the flu, what might grow in their lungs? Staph. And they're a farmer. They just delivered a baby cow in the barn, and now they got pneumonia and vomiting and diarrhea. Q fever. Coxiella burnetii. Wait, what did you guys say? What?
I said PTSD.
PTSD. Oh, no, wrong shelf. Okay, so these are kind of random, but you guys just took step 1, so you should remember this, right? Okay. What if they just skinned a rabbit? This actually was on my shelf. Tularemia. So if they live in Arkansas and skinned a rabbit, and they not because of Arkansas, but they've got it's a well-known geographic association. Whatever. Okay, tuberculosis. So remember, if the patient has symptoms and you're really worried about TB, got to get a chest x-ray to see what the involvement of the lungs is looking like. For screening, we give the PPD, and there are different thresholds for positive PPD depending on your level of risk. So if the PPD is positive, the next test is always a chest x-ray. If the chest x-ray is positive, we really want to get a sputum culture and do acid-fast staining of the sputum. If the chest x-ray is negative, it takes 3 negative sputum cultures to reassure us that we're okay. If the chest x-ray is positive, we got to treat them for 9 months, or 6 months, as it says here, with 4 drug treatments, and then we can narrow down after the sensitivities come back. A question I got wrong, so I put on this slide. The only people who get chemoprophylaxis, like if they have a known contact with someone with proven TB, the only people who are given INH for prophylaxis are little babies or little kids under the age of 4. Everybody else, you don't treat them until you diagnose it. So just being exposed to someone with TB isn't enough to warrant treatment. So they love the side effects of these medications. So what are some side effects of rifampin? Orange, right? My daddy went to UT. He always wanted to take this so he could be, patriotic for his school. So your body fluids turn kind of like a reddish orange. It's also an inducer of cytochrome P450. INH, neuropathy. So we give B6, pyridoxine with it. Pyrazinamide, kind of random. Eyes is ethambutol. Pyrazinamide really doesn't have very many side effects. It can give you a hyperuricemia, but it's usually not enough to cause gout. Ethambutol causes optic neuritis, and it's like E for eye symptoms with ethambutol. Okay, so endocarditis, the most common bug. Acute endocarditis. Staph. If it's acute, if it's attacking native valves, it's more common to be Staph aureus. If it's subacute on native valves, then the most common bug. Sorry, I said most common valve first. The most common bug is Viardens group strep, and the valve that's the most commonly affected is the mitral valve. Okay, so if they're an IV drug user, you're thinking Staph, and what valve does it attack? Tricuspid, yeah, it's more likely to be right. And remember, right-sided heart murmurs, I didn't mention it earlier, but right-sided heart murmurs are always worse with inspiration. So that's how you can tell the clinical vignette is pointing you in that direction. So we diagnose this with blood cultures, then we want to do an echo, and then there are major and minor criteria that I'm sure you've seen in your books. What are we worried about as complications for endocarditis? Yeah, so emboli, definitely. Emboli to either the lungs or the brain are an important complication. The most common cause of death is actually due to the just local destruction of the valve. So congestive heart failure is more common to kill them, but we do worry about emboli as well. So treatment for endocarditis depends on what they have. And prophylaxis for endocarditis, they like to ask questions about this. Who needs prophylaxis? So you need prophylaxis if you have a prosthetic valve, any kind of mechanical valve that's not yours. If you've ever had endocarditis in the past, you need prophylaxis. Or if you have like a VSD or a ASD, other congenital lesion that hasn't been corrected yet. Those are all indications for endocarditis prophylaxis. And, so important. What do you do if you find strep bovis bacteremia or strep bovis endocarditis? Colonoscopy, why? Because it's associated with colon cancer. Very good. Okay, so HIV is huge on this test, and the complications and other opportunistic infections associated with it. So when is the clinical vignette trying to suggest to you that they're talking about HIV? If the patient travels a lot for work, that in USMLE land means they have a lot of unprotected sex. I don't know why, and my husband travels a lot for work, so it makes me really nervous. Anyway, other things, remember the acute retroviral syndrome looks a lot like mono. So if it looks like mono, even if you're pretty sure it's mono, if, next best step is the question, an HIV test is an answer choice, pick it. If the young patient has a new Bell's palsy, and they're not pregnant, HIV can cause Bell's palsy. HIV can also cause thrombocytopenia. So if the patient just feels crappy and their platelets are low, do an HIV test. Anytime there's an unexplained weight loss, or you have any opportunistic type infections, if there's thrush, HSV, shingles, Kaposi sarcoma, any of those AIDS-related illnesses, suspect HIV. So in terms of treatment and prophylaxis, the highly active retroviral therapy, you usually start it when CD4 count goes below 350. That's the threshold. Or if the viral load is over 55,000. Pregnant ladies get a lower threshold because we want to prevent transmission. What am I doing here? Oh, these are side effects. So what HIV drug causes leukopenia, GI symptoms, and macrocytic anemia? Some of these are kind of random, but this one I would know. No, it's a drug. What HIV drug causes this? Out of this list, this is the only one I would memorize for sure. It's zidovudine. And the macrocytic anemia is important. If you've got an AIDS patient, they're anemic, you look at the smear and there are macrocytes, zidovudine is really, really classic for causing both a decrease in white blood cells and a macrocytic anemia. The rest of these are kind of random. Pancreatitis is caused by didanosine. Really bad hypersensitivity reaction can happen with abacavir. Kidney stones and hyperbilirubinemia can happen with adenavir. That's a protease inhibitor. And then, really bad psychotic symptoms happen with efavirenz, and that's a non-nucleoside reductase, NNRI. It's an NNRI. So, as far as post-exposure prophylaxis is concerned, anytime you have a needle stick injury with an HIV-positive patient, you're treated with a triple drug regimen for 4 weeks. So, not one drug, not 2 drugs. You always need the highly active retroviral therapy for known HIV exposure. So in our HIV patient, if they present to you with dyspnea on exertion, they've got this non-productive cough, fever, chest pain. Oh, I told you. We're thinking pneumocystis, right? So PCP is the most common opportunistic infection. And this is what the chest x-ray looks like. It's not very impressive. It's kind of some fluffy bilateral infiltrates on the chest x-ray. And of note that LDH can be elevated in the blood. The best test after a chest x-ray? Yeah, we want to see the sputum. We'll get, not sputum, but we'll want to get a sample. So bronchoscopy with bronchoalveolar lavage, we need that to actually see the bug. First line of treatment, trim sulfa. What if you're sulfa allergic? Dapsone or pentamidine. So dapsone with trimethoprim, primaquine clinda, I've never seen that used, but aerosolized pentamidine is another alternative. And then when do you add steroids? When it's really bad. When the pneumonia is so bad, their arterial blood gas dips below 70. And prophylaxis, when do we give it? Less than 200. Very good. So less than 200 CD4 count, we give it. Trimsulfa is the first line, and the same drugs used for treatment are second, third, and fourth line, respectively. Okay, so our HIV-positive patient has diarrhea. There are 3 main flavors of this. So CMV, MAC, and cryptosporidium can all cause diarrhea in an HIV-positive patient. With CMV, we can see this on colonoscopy and biopsy. We can actually, do staining for the virus, the intranuclear inclusions, and then we can treat it accordingly. MAC, it's kind of a diagnosis of exclusion. We can't really see. The biopsy is going to be negative on the colonoscopy. There won't be any stool, ova, or parasites on the testing. But cryptosporidium, those are the little parasites whose oocysts are acid fast. So with CMV, we can see it on biopsy. With cryptosporidium, we can use an acid fast stain for the oocysts. And MAC, we prophylax for that if the CD4 count is really low and we can't find another reason for the diarrhea. Okay, so HIV patients are also privy to a whole host of neurologic symptoms and neurologic problems. So if we see on CT multiple ring-enhancing lesions, what? Toxo, good. What if there's just one? Primary CNS lymphoma. How do we treat them? Pyrimethamine sulfadiazine, I think is how you say it, and you actually treat them both the same. Any ring-enhancing lesions in an HIV patient, treat with a trial of pyrimethamine sulfasalazine, and if it gets better, we know it must have been toxo. If that one lesion is still there, we're thinking maybe it's CNS lymphoma, and you might consider a biopsy. So really multiple versus single helps you see whether infection or cancer is more likely, but in real life and on the test, you treat them both the same. You treat them with antibiotics and see if it helps. So If a HIV-positive patient has a seizure and they have this weird deja vu aura, and then you do a spinal tap and there are 500 RBCs in the CSF, that's characteristic for... Anybody done neuro? Where does a deja vu aura tell you about a seizure? Where did it start? Temporal lobe. What virus goes to the temporal lobe? HSV. HSV is also known to have a small amount of red blood cells in the cerebral spinal fluid. It's a hemorrhagic, slightly hemorrhagic spinal fluid. So HSV encephalitis is what we'd be thinking there. And we treat with acyclovir ASAP. As soon as you suspect it, don't wait for viral culture, don't do an EEG, treat with acyclovir as soon as you can. So the most common cause of meningitis in an HIV-positive patient, it's actually strep pneumo. But what else are you worried about, opportunistic infection-wise? Yes. So cryptococcus is a consideration in an HIV-positive patient. Don't get me wrong, the most common cause of meningitis is still strep pneumo, whether they're HIV positive or not. So we'd be worried about cryptococcus, though. We do an India ink test to look for that, and amphotericin IV is the drug of choice. What if our HIV patient has hemisensory loss, visual problems, and a Babinski? Kind of sounds like MS. These patients kind of present with a picture that looks like multiple sclerosis. That's associated with a virus. AIDS patients get it. Think back to Dr. Krolik back in the day. It's PML, the JC polyoma virus. Y'all remember that? So this disease is demyelinating. That's why it has symptoms that are similar to MS, and it preferentially affects the gray-white junction. So here we really need to do a brain biopsy to tell whether or not we've got it. And it doesn't really matter because there's no treatment. The treatment for PML is just to improve the CD4 count. And lastly, if we've got an HIV patient, this is sad. They're like in their 30s and they've got like pretty bad dementia, not walking well, not remembering stuff well. There's no other cause. Yeah, AIDS dementia complex. So not really anything we can do. You rule out all the treatable causes and then give supportive care. Okay, so neutropenic fever. Is that a big deal? All right, so when they present to the ER, what are you not going to do to them? Stick your finger in their butt. So neutropenic fever patients never get a DRE. Why not? You can induce bacteremia in these patients by inducing translocation of normal gut flora across the wall. So never ever digital rectal exam. So we define neutropenic fever by a single temp that's super high or a sustained temp that's a little bit more low grade for more than an hour. And the absolute neutrophil count is less than 500. So the most common cause of bacteremia, we kind of hinted to this, is mucositis. Anywhere along the GI tract, the bacteria can just translocate due to the inflammation. Most common bugs here are Pseudomonas and MRSA, especially if they've got a port for chemo. And the workup here, you always want to get a blood culture. And then start antibiotics. So ceftazidime and cefepime are the most common drugs of choice. So we'll add vancomycin if they've got a port or you've got reason to suspect a line infection. And if the patient doesn't get better within 5 to 7 days, add amphotericin because maybe it's fungal. So things to remember for the exam, this is a big deal, and don't put your finger in their butt. So other random infections, what gives you a targetoid rash, fever, cranial nerve 7 palsy, meningitis, AV block? Lyme disease, it can do anything. What do we treat it with? What if I'm a 6-year-old kid? They can't have doxy, amoxicillin. Good. That's kind of a dirty question. That's more of a peds thing, but it could be on there. So what if you have a rash that's at your wrist and ankles, palms and soles, fever and headache? Rocky Mountain spotted fever, what do we treat it with? What if I'm a 6-year-old kid? Doxy anyway. Rocky Mountain spotted fever, amoxicillin doesn't work. So even if the kid is under age 8 is the cutoff, everybody gets doxy for Rocky Mountain spotted fever. So what if you've got a history of a tick bite? The dude saw the tick bite him, but there's no rash, but they do feel like crap. They've got myalgia, fever, headache, Their platelets are also low. This is a random one. Oh my God, you guys are so good. I pimped my radiation oncology resident on this today, the chief resident. I was like, hey, what are the symptoms of ehrlichiosis? He was like, screw you, go write the patient note. True story. Anyway, we also treat this with doxy. So take home message, if a tick bites you, take doxy. Because no matter what it is, even if you can't remember what exactly the bug is, if the question is how to treat it, the answer is doxy, unless you're a little kid and you're suspecting Lyme. So what about in an immune-suppressed patient? They've got a cavitary lung disease, weight loss, fever, and when you look at the sputum, it's got gram-positive bugs that are branching, and they're partially acid-fast. Nocardia, very good. So nocardia, those are the ones that are aerobic, because they're in the lung, and that's where air is, and you treat it with trimsulfa. What about the other branching bacteria that is anaerobic? Yes, that's actinomyces, and for this we need high-dose penicillin. Okay, good. So the kidneys, my favorite organ. I love the kidneys. So with nephrology always comes electrolytes and fluid balance. So remember that hyponatremia is caused by too much water. So the first things you want to do are check the osmolarity and then check the volume status. Are they hypovolemic, euvolemic, or hypervolemic? So some causes of hypervolemic hyponatremia, congestive heart failure, nephrotic syndrome, cirrhosis. Hypovolemic hyponatremia, that's if you're losing a lot of fluids either by taking too much Lasix or vomiting. And then euvolemic hyponatremia, really the main thing it should make you think of on the test is SIADH. So if they're a smoker, it's chest x-ray city. So more importantly for your exam, how do we treat it? So normal saline, obviously, anytime the patient is hypotensive or shows symptoms of being fluid down, just give them normal saline because that's how we resuscitate them. The only time you would give hypertonic saline, 3% saline, is if they're symptomatic, if they're having seizures related to the low sodium, or if their sodium's in the toilet, less than 120. Otherwise, if they're not volume down, and if they're not having seizures, you just fluid restrict them and wait for the fluid balance to come back into equilibrium. Why don't we want to treat this too fast? Central pontine myelinolysis. So the magic number, you don't want to treat more than 12 to 24 milliequivalents per day. So that's like 0.5 to 1 per hour. And then hypernatremia then conversely is due to a loss of water, and we treat it by replacing water. So that's about it. Again, we don't want to go too fast here because we can see cerebral edema as the adverse effect of that. So central pontine myelinolysis when you correct hyponatremia, cerebral edema when you correct hypernatremia too aggressively. All right, so what if your patient has numbness, those dead guys who I can't say, or a prolonged QT interval? Hypocalcemia, very good. What about bones, stones, groans? Crazy. Hypercalcemia. Hypercalcemia, good. What if they've got some paralysis, they're very constipated, when you do an EKG, you see ST depression and some U waves? Hypokalemia, and those peak T waves we saw earlier? Hyperkalemia, oops, that's how you treat it, hyperkalemia. More importantly, how do you treat hyperkalemia? Because you might very well get a question on this. Calcium gluconate is first, why? Stabilizes the cardiac membranes, right? So that's first, but that doesn't do anything about having too much potassium in your body. So what do we do for that? You can do K-exolate. A lot of hospitals don't do that, but they still use it at the VA. K-exolate basically makes you poop out potassium, so that helps. What else? Insulin with glucose too, right? So insulin to drive the potassium into the cells, but we still have too much in our body. How do we get rid of it? Diuretics. Good. So that's the treatment regimen. So calcium gluconate, insulin and glucose, K-exolate. Albuterol works through a similar mechanism to insulin, and then and diuretics to get rid of it. Last resort, if the patient's really symptomatic and potassium is sky high, it's an indication for dialysis. So acid-base disorders, I won't belabor these, let's just hit the high points. If the bicarbonate is high and PCO2 is high, and they are alkalotic, then we know it's metabolic. And the next test then to do would be a urine chloride, because that's how we tell what is causing the metabolic alkalosis. So if the chloride is high, then we're thinking maybe we've got a hyperaldosterone state, whereas if the chloride is low, then we're doing something to lose chloride, either too aggressive NG suction, too much throwing up, so forth and so on. So if we've got an alkalosis where CO2 is low and bicarb is low, that's respiratory, right? So we're blowing off too much of the CO2. That's like in our asthma attack patient in the early stages. So if bicarb is low and PCO2 is low, that's describing a metabolic acidosis. And the next thing to calculate, if they give you the information to do so, is the anion gap. So remember that normal is 8 to 12, and if it's elevated, start thinking about one of those items in the differential that fills out that mnemonic mud piles. And then non-gap metabolic acidoses, there are fewer causes there. Diarrhea and diabetic use are the main ones. And then those silly renal tubular acidoses. Anybody else have a hard time with those? Me too. I got a slide on them coming up. And then PCO2 is high and bicarb is high. That's a respiratory acidosis. Hypoventilation is the overwhelming cause of that. So let's talk about these RTAs. They're a cause of non-anion gap metabolic acidosis. So type 1, is it proximal or distal? Distal. And the cause is lithium is the main one that I've seen in clinical vignettes. And at presentation, the things to remember are that the urine is alkalotic and in the blood there's low potassium. So how do we treat type 1 RTA? We'll give them bicarb. We'll give them bicarb. Because the problem is with proton excretion, giving oral bicarb will help. That's in contrast to type 2 that we'll talk about right now. So type 2 is proximal. The most common cause that I've seen in clinical vignettes is multiple myeloma. And it's also hypokalemic on presentation. But the problem is they can't reabsorb bicarb. So giving bicarbonate doesn't solve the problem here, because our problem in pathogenesis is we can't reabsorb it. So here, we just give a mild diuretic and replete the potassium. So type 4 is hyperreninemic hypoaldosteronism, and the overwhelming majority are caused by diabetes. So that's the important thing to remember for your clinical vignettes. On presentation, the thing that differentiates it from type 1 and 2 is that they're hyperkalemic, which makes sense, right, if they've got low aldo. And we treat this by repleting mineralocorticoids. So we give them fludrocortisone. So I think to get these questions right on the test, remember the major causes of the 3 types, remember what potassium does, and remember how to treat them. And I think really, and then remember between 1 and 2, the difference between distal and proximal, and whether the problem is protons or bicarb. And you should be able to get all the questions right that they could ask you with that information. Okay, definition of acute renal failure. ARF. Has to do with what thing on chemistry? Creatinine. Okay, does it go up or down? Okay, you're awake, so it goes up. And how much? It's kind of loosely defined. There are a couple different definitions depending on the source. In general, if there's an overall increase by 25% or a net increase of 0.5 over baseline, it's acute renal failure. And to further work it up, you want the BUN creatinine ratio, because that can help you determine between pre-renal and intrinsic renal causes. You'll also want to check the urine sodium and creatinine so you can calculate the FeNA, and you will have to do that on your test, probably. And then remember, if the patient's on a diuretic, the FeNA is not reliable. You need to calculate the phenuria. And why is that? Yeah, so if you're on a diuretic, even if your body would naturally want to hold on to it in the pre-renal state, you're going to be peeing out all kinds of sodium because you're taking a diuretic that blocks the channels. So it's not a reliable indicator. So treatment is easy if it's pre-renal. You'll want to replete the fluids or otherwise reverse the cause of the pre-renal azotemia to begin with. And it can be caused by anything that prevents blood flow to the kidneys, either because of global hypoperfusion or renal artery stenosis, anything that keeps blood flow from getting to the kidneys. So intrinsic causes are a little bit more interesting. So what would be the cause of renal failure in a patient who has muddy brown casts? They just took some amphotericin, aminoglycoside, cisplatin, and they had prolonged ischemia. Okay, ATN, good. So muddy brown casts on UA, that's the hallmark of ATN. What if the patient has protein in the pee, blood in the pee, eosinophils in the pee, and they also have a fever and a rash after they took some trimsulfa? Yes, that's AIN. And the treatment here, obviously we're going to stop the drug that's causing it because this is an allergic reaction that occurs in the kidney, and steroids can also be added if it doesn't resolve on its own. So if we've got an Army recruit or crush victim, CPK is sky high, there's blood on the dipstick, but negative red blood cells. Rhabdo, yes. So first test, this is important. If you suspect rhabdomyolysis, you need to either check potassium or get an EKG. You always want to think about what's going to kill your patient. ATN, renal failure is not going to kill your patient immediately, but hyperkalemia will, right? It can cause arrhythmias and death. So if you ever suspect crush injury or suspect they're trying to point you in the direction of rhabdo, get a potassium level or an EKG. So what if you see envelope-shaped crystals on the urinalysis? Yeah, life's not that bad, right? Don't drink the antifreeze. So ethylene glycol intoxication will give you envelope-shaped crystals, and that causes an anion gap metabolic acidosis. And then if you get a bump in creatinine a day or 2 or 3 days rather after a cardiac cath or a contrast CT, good, contrast-induced nephropathy. The timeline is important here. 48 to 72 hours is very characteristic if contrast-induced nephropathy is going to happen. All right, so the 5 indications for emergent dialysis. What's the A for? Acidosis. E? Electrolytes, specifically potassium. I? Intoxication, specifically of? Ethylene glycol or lithium, sure. O? Super bad CHF. U? Uremia. So what they might say to suggest uremia in a clinical vignette, pericarditis or like really bad confusion, altered mental status. So don't fall into the trap. A creatinine of 1 million is not an indication for emergent dialysis. Well, maybe 1 million, but not a high one. Okay, so for chronic kidney disease, you know this from working with our population. The number 1 cause is diabetes. Second most common is hypertension. Most common cause of death are cardiovascular complications. So the complications you'll look for, this will be in a vignette that's describing an outpatient visit. Hypertension can cause CHF. You can get an anemia because the kidney disease leads to a loss of erythropoietin. There are electrolyte abnormalities you can see, high potassium, high phosphorus, and low calcium. And then you can get a secondary hyperparathyroidism. The low calcium, because of the kidney disease, tells the parathyroid gland to ramp up PTH. And then uremia, we talked about the symptoms of that. The other one I would add are bleeding after an operation. So that could show up on your surgery shelf or your medicine shelf. Uremia from chronic kidney disease causes the platelets not to clot properly, so they're at an increased risk of bleeding. So your patient's peeing blood. Best first test. UA. What if painless hematuria? It's what until proven otherwise? Cancer. So either of the bladder or of the kidney. Terminal hematuria, that means you're peeing fine and then you got a few clots at the end. That's bladder cancer. Very good. If the blood cells look like little Mickey Mouse ears, yeah, that's glomerular problems if they're dysmorphic. The definition of nephrotic syndrome? So proteinuria, but not nephrotic range. What else? Hematuria, hypertension, and kidney failure, azotemia. So, good. And so what if you're peeing blood 1 to 2 days after a runny nose, sore throat, and cough? This is the most common cause of nephritis. What? Not 1 to 2 days later. And this is after like a virus. Runny nose, cough, kind of like flu-y type stuff. Burgers. So IgA nephropathy, the timeline is important. See the difference between these two? 1 to 2 days later, and if they're more viral symptoms, that's Burgers, IgA nephropathy. If it's 1 to 2 weeks later, and they had a sore throat or impetigo, then you're thinking post-strep. So it seems silly, but the time course really is the determining factor here. Hematuria plus hemoptysis, that's bad. Good pastures. Hematuria plus deafness, and maybe a positive family history. Alports, good. Very good. And those are both problems with collagen 4, either an antibody against it in the basement membrane or a mutation in it. All right, so what if you're a kiddo peeing blood after an infection, and also with arthralgias and purpura and abdominal pain? Enoch Sean line, good. A kiddo status post hamburger and diarrhea with renal failure. It must have been late when I was making this slide. Yes, that's HUS. Good. The MAHA is microangiopathic hemolytic anemia and petechiae. Those are other symptoms of HUS. A cardiac patient after ticlopidine and renal failure, MAHA, low platelets, fever, and altered mental status. TTP, good. So why is the ticlopidine in there? It's been shown to cause TTP. So they actually don't use ticlopidine very much anymore because it shows an increased risk of having TTP. So the important thing to remember here, the treatment is emergent plasmapheresis. Do not give platelets to these patients. That will be an answer choice. Do not choose it because the process that's consuming the platelets and causing the thrombocytopenia is going to just continue to consume any more platelets you throw in there. So this can be a confusing clinical picture to confuse with DIC. You can tell the difference because your coags will be normal in either HUS or TTP. Prothrombin time and PTT are both going to be normal. So a patient who has C-ANCA, kidney and lung and sinus involvement, and they're peeing blood. Wegener's, good. P-ANCA, asthma eosinophilia. Scherg-Strauss. P-ANCA, no lung involvement, and they might have Hep B. Yeah, here's polyarteritis nodosa. Good. Okay, so kidney stones, they hurt like the dickens. The best test is a CT, because that's going to detect all stones, not just the ones that'll show up on an X-ray. The most common type of kidney stone? Calcium oxalate. A kid who has a family history of kidney stones? Cystine. Chronic indwelling Foley, and their pee is very alkaline. Good. Struvite stones from any type of bug that's got a urease. So Proteus, Pseudomonas, Klebsiella, or staph. If a kiddo with leukemia is being treated with chemo and then they develop stones. Uric acid stones, good. And if after a bowel resection for volvulus, you're at risk for pure oxalate stones. And that's because if you have a large segment of bowel that's resected, you can't adequately reabsorb the calcium. So the oxalate that's left behind precipitates out and makes a pure oxalate stone. So little bitty stones, how do we treat them? Yeah, sucks to be you. So got to pass them, give them some fluids. If it's a ginormous 2-centimeter stone, for the super giant ones, we cut them out. For the medium-sized ones, we'll use lithotripsy. So super small, tough luck, got to pass it. Super huge, we'll actually surgically remove it. Somewhere in between, we'll break it up and let the fragments pass. So for proteinuria, the best first test is to repeat the UA, because it may just be a transient finding. The definition of nephrotic syndrome, that's we have proteinuria on the larger scale, greater than 3.5, also low albumin, edema, and hyperlipidemia. So what they might describe in the vignette are some fatty or waxy casts. The most common cause of nephrotic syndrome in kiddos? What? Minimal change. And in adults? Membranous. Good. What about in a patient who's using heroin or has AIDS? Focal segmental. Associated with chronic hepatitis. Membranoproliferative. And this is important right here. If a nephrotic patient suddenly develops flank pain, are you worried about that? Is it a kidney stone or what? You're worried about renal vein thrombosis. Absolutely. So why? Why are we so scared about renal vein thrombosis in a nephrotic syndrome patient? Absolutely. So we know they're peeing protein, right, because their glomeruli suck. They're also peeing out clotting factors and coagulation necessary things. So renal vein thrombosis is always the biggest fear if someone with nephrotic syndrome gets flank pain. And some other random causes, you can have just orthostatic proteinuria, multiple myeloma can cause proteinuria, pregnancy can cause proteinuria, fever, or congestive heart disease. Okay, so some hem-onc stuff. This is probably the last section I'll be able to cover. So we've got a patient who walks in with microcytic anemia and this smear and these labs. So the MCV is 70. It's kind of low. Low iron, high TIBC, low retics, RDW, and ferritin. So that's iron deficiency. What if we've got the same smear and the only thing that's different is the TIBC is low? Now we're worried about chronic disease for number 2. For number 3, check out this smear, and the MCV is super low, 60. What? Thalassemia, absolutely. So thalassemia is characterized by a really low MCV, and what is the significance of the low RDW? Yeah, there's little variation, right? If it's a genetic defect, all the red blood cells are going to be affected by the thalassemia. Whereas in another cause, there might be more retics, so there's going to be greater variation in the size of the red blood cells. So what about this little microcytic friend? 70 MCV. The iron is actually high, low TIBC, high ferritin, and this smear. Can you see it well on this thing? It's sideroblastic anemia. It's sideroblastic anemia. So this one, you'll see ringed sideroblasts in the bone marrow, which we can't see on the smear. And other things that might help you in the clinical vignette, isoniazid can cause sideroblastic anemia. So they might tell you that the patient was on INH for tuberculosis. Okay, so for macrocytic anemia, if you see one of these dudes, what's that? It's a hypersegmented neutrophil. So what if this is your vignette? High MCV, high homocysteine, but normal methylmalonic acid. That's folate. What's up, step 1? Okay, so that's folate. What if both homocysteine and methylmalonic acid are high? That's B12. And they might give you neurologic symptoms also. If the MCV is high and you've got one of these dudes, this is called an acanthocyte. Remember that from Nan Claire? What would cause that? Liver disease. So liver disease is another cause of macrocytic anemia, and acanthocytes on a smear help us out. I'm going to tell her y'all didn't remember. Okay, so what if the MCV is normal, but LDH is high, so is indirect bilirubin, and the haptoglobin is low? What are we worried about? What would cause high LDH in the blood, high indirect bilirubin? Hemolysis. So these are all cases of hemolytic anemia. A sickle cell kid with a sudden drop in hematocrit, that's an aplastic crisis or a sickle crisis. So the causes for that are either hypoxia, dehydration, or acidosis. If you have cyanosis of the fingers, ears, nose, and maybe had a walking pneumonia, cold agglutinins, and the destruction of the blood cells are due to IgM, immunoglobulins. If there's a sudden onset of hemolytic anemia after you take some drugs, penicillin, cephalosporins, sulfas, warm agglutinins. So G6P can be precipitated by sulfas. Yeah, so that's really not fair. I was trying to get at warm agglutinin disease here. It's caused by either a drug reaction or an underlying malignancy. And the difference here is instead of IgM, it's mediated by IgG. So if the spleen is big, there's a positive family history of this type of illness. There's bilirubin gallstones. The mean cell hemoglobin concentration is high. Yeah, hereditary spherocytosis. We got to treat that by taking out the spleen. If they're complaining of peeing really dark when they first wake up in the morning, they might have Budd-Chiari syndrome, or clots in the IVC. PNH, yes, paroxysmal nocturnal hemoglobinuria. And from step 1, that's a defect in, whatever, I don't remember that. Okay, so here's the one you were trying to get at earlier. Sudden onset of hemolytic anemia after permaquin, sulfa drugs, or fava beans, which I had the other day. They're delicious. There's our G6P dehydrogenase deficiency. Okay, so with thrombocytopenia, low platelets on our CBC. If it's a young woman who's got recurrent epistaxis, really heavy menstrual bleeding and petechiae, and when you do the CBC and all the workup, the only thing that's low are the platelets. That's what? ITP. So prednisone is medical management, splenectomy if that doesn't work. What if it's a young woman with recurrent epistaxis, heavy menstrual bleeding, petechiae, but the bleeding time and the PTT are high? Ooh, not DIC. Von Willebrand's, yes. So why is the PTT high in von Willebrand's? Yeah, because von Willebrand's is bound to factor 8. Very good. So now I've got a 20-year-old male who's got recurrent bruising, hematuria, hemarthroses, elevated PTT, and we correct it with mixing studies. Hemophilia. What's this mixing studies business? It means something's deficient, right? So if you've got a problem with PTT and you mix it with normal blood and it corrects, that means something was missing in the patient's blood that you added when you mixed. So that's what a mixing study does. If you have a mixing study, you've got an elevated PTT, and then you put in normal blood and it still doesn't work, that means there's an inhibitor that's present. So even if you add the factor, the inhibitor in the patient's blood is going to screw it up. So our fourth patient is a 50-year-old meatitarian, just finished 2 weeks of clindamycin, has hemarthroses and oozing at his venipuncture sites. Vitamin K deficiency. I thought I was being tricky, but you guys got it. Right? He's a meatitarian. He doesn't eat any vitamin K rich foods. And he took Clinda, so he wiped out all his gut flora. He doesn't have vitamin K. What about a 50-year-old beeritarian with severe cirrhosis and thrombocytopenia? So why would liver disease cause thrombocytopenia? Yeah, because your liver makes your factors, right? So if your liver's shot, you're not going to make them. What's the first one depleted? 7. And so the PT, what that means for us clinically is in early liver failure, the PT is going to rise first before the PTT, because factor 7 is the first one to go. And the 2 factors not depleted in liver failure, because they're made in the epithelial cells or endothelial cells. 8 and von Willebrand's. So they're not made by the liver, so liver disease doesn't affect them. Okay, so we'll go through a couple more slides, and then it's going to be 9 o'clock, so we'll have to stop. So if a patient walks in with thrombocytopenia and this, is that scary? What is that? Schistocytes. So that's scary. And if the PTT and PT are both high, fibrinogen is low, D-dimer and fibrin split products are high, there's your DIC. So what causes it? Sepsis, right? LPS from gram-negative sepsis, some OB stuff, some other things. Oh, when you treat M3 AML, remember that? The hour rods, that causes DIC. Snake bites. Don't get bit by a snake. Okay, so there's some of the causes. The treatment, not much works, right? You got to correct the underlying factor. You can give FFP to replace the fibrinogen. You can transfuse platelets in this scenario, but really, unless you correct what started this whole thing in the first place, you're kind of toast. If the PT and the PTT are normal, but we still have the smear, TTP, good, we just talked about it. So HUS or TTP, and the causes of that O157H7 causes HUS, and then there are some drugs that are associated with TTP. The most important one for you is going to be ticlopidine. And then the treatment, do we want to give them platelets? No? What do you want to do? Plasmapheresis. Good. So if you're going to go into pathology, TTP is like one of the only things they'll page you for on the weekends. Little known fact. Okay, so 7 days post-op, a patient develops a clot in their artery, one of their arteries, and the platelets are low. So low platelets, but clots. Heparin, yes, HIT. So post-op, they probably got heparin during the operation. That's going to cause HIT. The mechanism is an antibody that binds to heparin and the PF4, and we treat it by stopping the heparin and start lepirudin. That's the anticoagulant of choice for that. And in somebody who has a thrombus that's unprovoked, you always want to think about cancer, especially if they're old. Lupus anticoagulant, you would see high PTT. They might have a history of multiple spontaneous abortions and a false positive syphilis test. For protein C and S deficiency, that's where you see that really nasty skin necrosis after warfarin. And we had a picture of this on my medicine shelf. They gave you like a really nasty, like awful bruised looking nasty thing, and it was after you'd given them warfarin, and they asked what the mechanism was. So it's protein C and S deficiency. Factor V Leiden is the most common cause of hypercoagulable state. AT3 deficiency is important to you because heparin won't work in those patients with AT3 deficiency. And then estrogen, we can't give that to women if they're old and they smoke because they increase risk of clotting. And nephrotic syndrome, we already talked about that mechanism. We pee out our clotting factors, and it puts the patients at risk for renal vein thrombosis. So I think it's 9, so we should probably stop. This was my last section, and I'll post it so you guys can look through my slides. I tried to make it pretty self-sufficient so you can use them to study. But it is 9, right? I can't really see the clock. Yeah, I don't want to keep you late. Yeah, no problem. I'll be here for questions if your brain's still working enough.